Lorian, in the two previous interviews, we've touched upon this idea that the Premier Danielle Smith wants Albertans to spend more of their own money on their health care. And she actually made a specific proposal in this paper, 2021 paper she wrote for the School of Public Policy at the University of Calgary, and she called for health spending accounts. What exactly were those?
Yeah, so the idea is that Albertans would get a set amount of money per year, and that money could then be used to pay for some of the services that are outside of the public system. And so, if we were to get that money today, people would spend it on things like prescription drugs or dental or those sorts of things. But there are really two worries. One is that giving everyone the same amount of money isn't reflective of their healthcare needs at all. And then the other issue is that right now, people would use those spending accounts on things like drugs or dental that are uninsured. But there's a concern that this could be coupled with slowly delisting public services and then that amount being expected to cover things that previously were covered, like physician services.
Yeah, we in the previous interview we talked about how she had advocated for the shifting the debate from what should be delisted, if anything, over
Yeah.
to what should be publicly funded. Presumably, some things would drop off the list, and then that would be covered by the health spending accounts. That's the worry. And I think that's while that isn't argument isn't made explicitly in her paper, I think you can infer from what she said that that's kind of the direction she wanted to go. Where she talks about people getting used to it. Now, she did say $375 per person. That's what she suggested, and that'd be matched by so the government would contribute that, and then she said encourage individuals and employers to match. But it's the bringing in the employers thing that really caught my attention, because now essentially what she's saying is, oh yeah, you might have to pay that, but your employer might have to pay it. Maybe it's not you, or maybe it's not all you. And, for a lot of people, they would say, oh, okay, well, it's not coming out of my pocket. So it makes it more palatable to grease the skids for change.
Yeah. And the concern is the same amount of money people are getting regardless. I mean, I have a job in the public sector. I have public insurance. What am I going to do with some sum of money that's either directly from government or that they somehow incentivize or push my employer to contribute on my behalf? Ultimately, it would be November and December, and I would be getting massages to use up this money. That's not needed. You have other people who aren't employed or who are employed in a way that doesn't give them benefits, so not enough hours for benefits, or a job that doesn't give benefits. And if those people have health issues, they could burn through that $375 by February. If they're having to buy medication for a chronic illness and they fall just above the government's cutoff for public insurance, or they have a major dental issue, root canal, whatever, they could burn through that money by February, and then you're left with nothing. And so it makes much more sense in terms of giving people what they need to have those costs be part of the public system. And so you don't have people who aren't able to pay for their drugs and other people who are getting massages to use that money. Instead, you have all of the money going to those who need it most.
Here's another interesting idea. She floated the concept of nonprofits contributing for low-income residents who couldn't, they run out of their health services account, as you say, in February. What do they do for the next 10 months? Well, they could maybe go to a nonprofit that would be set up and apply for charity. And this was a real problem for me, because decades ago, this is how things like welfare were set up, where you had to apply to a charitable organization or something, and there was a lot of stigma attached to it, and there wasn't, the amount of money available was very low. And so for her to suggest that low-income Albertans should have to apply to a charity to pay for their health care, what do you make of that?
it's inefficient. I mean, who are these charities that are going to provide the services? Where are they going to come from? How are they going to be resourced? How are people going to jump through the hoops to get benefits from them? You know, if the government wants to increase access to, say, dental, then giving everyone the same set of pharmaceuticals, giving everyone the same amount of money doesn't do that. If the government wants better access to pharmaceuticals, then they can take the current income level that you need to qualify for those benefits and raise it. So that you have the people who are just falling outside of getting public benefits right now and aren't able to buy drugs or to buy dental or whatever the case may be, cover those people. Don't give everyone and their dog 300 and however many dollars, whether they need it or not, and push people on to trying to get care from these non-existent nonprofits that we don't know where they're getting money from. Instead, just lower the income ceiling, provide people with benefits through this system that you already have set up, far more efficient, a lot more certainty around that kind of option. It just isn't clear what all of this is supposed to achieve.
Here's another thing she proposed: co-payments. Now, this will be foreign to most Canadians, but I mean, when I was working down in the US 20 years ago, I ran into, that was a frequent topic of conversation around lunch because, what did you pay for copay? Oh, what was your copay for copay? And some of them, the deductibles were really high, like $3,500 or $5,000. And so that was seen as a real burden by working people and even professionals, because it was tough well, it made things difficult financially. What's your take on that?
I think we've a lot of evidence from various jurisdictions to show that co-payments, and of course even from Canada, if you look at things like the pharmaceutical context, things like having to hit a certain deductible before your insurance kicks in, or having to have co-pays every time you go to the doctor or the hospital, that all of that does affect those with lower incomes, especially really hard, and to the point that they may not seek health services that they need. And people will not go to the doctor because of a copay or delay an emergency room visit because of a copay. And all of that, of course, has a significant impact on health. And insurers and public insurers, private insurers, people paying out of pocket, all of this billing, all of this administration, the administrative costs of that are extremely high. And again, if we look to the US, the amount of money spent on administration in that country dwarfs what we spend on administration to have a single payer system.
In fairness to her, she did propose a graduated copayment structure. So under 75,000, there'd be no deductible. 75 to 150,000, there'd be a $500 deductible, and over 150,000, there would be a $1,000 deductible.
Yeah.
My problem with that is that's where they might start. Where does it end up? Because that would be, yeah.
That is true. That's where they start, and we may see them erode over time. The other thing is that you can have someone who seems to have a relatively high income, high enough to fall into that first category of people paying co-payments or having a deductible. They could still have very significant medical costs, to the point that actually is burdensome for them to pay that. So, and again, the administrative costs to collect these and enforce these and all of that, it's just like, are we getting good value for the money that would bring in? And I think the evidence would suggest the answer is no.
This is the third interview that we're doing on this part of a multi-part series. And the one you keep coming back to, the evidence doesn't say that.
Yeah.
Experts who are grounded in evidence don't believe that, and there was none of that in her paper. This was all very much a part of a kind of a narrative.
Yeah.
She was making an argument, fair enough, but there wasn't a lot of evidence and a lot of data and so on to back it up. And this would appeal, I think, to people who already believe what she believes. Who are
Yeah.
more geared to the private sector. But to be very clear, in your experience, because you're in the Faculty of Law at the University of Calgary and the Faculty of Community Health,
Yeah, faculty medicine. Yeah.
and the evidence doesn't support her argument overall in the paper. That's what you've been.
No, it really doesn't, and we can look at these kinds of experiments that have been tried in other countries or even in Canada for certain healthcare services, and it really doesn't support what she's saying. Her paper is extremely thin on any sort of evidence, footnotes, citations, studies, any of the things that I think we would want to back up such a fundamental shift in the way we deliver healthcare services. But I think in general, this isn't just this paper or this topic. What we've seen under Premier Smith is a turning away from experts, a turning away from evidence, and really an ideological approach to the healthcare system, where the policy is picked for ideological reasons, and then people ask for evidence after the fact. Well, where did this come from? Why are you doing this? And either very little is produced, or sometimes you'll have some cherry picked examples. But really a lot of people who work in this space shaking their heads, wondering where these ideas are coming from.
Well, where they're coming from is this paper, because it really is, I think, a blueprint. Not everything that she's done is contained in there, but the basic principles and ideas are consistent with the healthcare policies of her government over the last 3.5 years. Lorian, thank you very much for this. This has been a fascinating conversation.
Thank you for having me.